بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا أكرم الأكرمين. Dear colleagues, now we are handling the next topic, which is the infra-hyoid neck, and this topic is divided into two parts. The first part will deal with the cysts in the neck as well as the vascular lesions. And you remember that we have tackled this subject, which is imaging of the larynx before. Then the second part of the infrahyoid neck will be about the imaging of lymph nodes, the thyroid gland, and the parathyroid glands. Now we'll talk about the imaging of the neck cysts, and you remember that we discussed the vision position and the scanogram in the lateral view. And we finished about the suprahyoid neck, starting from the level of almost the hard palate, ending at the hyoid bone. Then we're starting the infrahyoid neck, starting just above the level of the hyoid bone, and we end by the trachea. Then the scanning sections are usually at 2 or 3 millimeter scan intervals. And you remember, we do not give the patient any instructions about breathing or swallowing. Many times we need to inject intravenous contrast media, and the use of 2D and 3D images, of 2D in particular, 2D images are helpful in the diagnosis. Then soft tissue window settings are performed for all images, and the bone window images are used to detect any bony or cartilaginous abnormalities. The same protocol applies for the MRI using the T1 and T2 weighted images, and we may need the help of contrast media, and in these cases we may have the fat suppressed images before and after intravenous contrast injection. This is the usual division of the neck imaging in general. And there you have the suprahyoid neck, which we have finished already, including the tongue and the mouth floor pathology, as well as the salivary glands. Then the parapharyngeal space is discussed separately because it extends from the supra down slightly into the infrahyoid neck. Then here we are discussing the cystic lesions of the neck, vascular pathology, and we have discussed before the laryngeal lesions. And finally, the second part of the infrahyoid neck will deal with the neck lymphadenopathy, imaging of the thyroid and the parathyroid glands. Then, as a general rule, we have three famous cystic lesions in the neck, and these are the thyroglossal duct cyst, the branchial cleft cyst, and the cystic hygroma. It's easy to remember that one of these cysts is almost in the midline, which is the thyroglossal duct cyst, and the other two cysts are located on one side of the neck. And you also know that the branchial cleft cyst is a small lesion compared to the cystic hygroma, which is usually big. Then if you see a midline cystic lesion in the neck, you think of thyroglossal duct cyst. If you see the cyst is laterally located, then look to its size. If it is small, it is most likely a branchial cleft cyst. If it is big, then you are dealing with most likely cystic hygroma. Then these cystic lesions usually present in infancy and early childhood. They are most commonly asymptomatic and compressible because of their cystic nature, but they are liable for complication, like especially this infection and the development sometimes of neoplastic lesions within the cyst. Starting by the thyroglossal duct cyst, which is a cyst following the thyroglossal duct, and this duct starts from the foramen cecum at the back of the tongue and extends across the neck, representing the course of the thyroid gland until it reaches the normal location of the thyroid glands in the lower part of the neck. Then this lesion is usually located in the midline or slightly off the midline. Sometimes the average size is about 2 centimeters, but it may be bigger or smaller. And 80% of the lesions are usually located at the level of the hyoid bone or slightly lower than the hyoid bone. And this cyst is rare in the mouth floor to be here. You remember we have 3 cysts in the mouth floor, 1 located laterally, which is the ranula, and 2 are located in the midline, which are the epidermoid and the dermoid cyst. And I have mentioned how can you differentiate these from each other. And the thyroglossal duct cyst may regress spontaneously, but about 5% of the cysts will remain, resulting in either a cyst formation or the fistula, or sometimes you can see a solid thyroid tissue at this along the course, especially near the foramen cecum, and this is what we call the lingual thyroid or the ectopic thyroid. Then this cyst, as I have mentioned, is painless, usually located in the midline. It moves up with tongue protrusion because of its intimate relation to the base of the tongue, and it may respond to antibiotic therapy, especially if it is infected. And you remember that 1% of the cysts are associated with thyroid carcinoma, usually the papillary type. And this is an example of a thyroglossal duct cyst, almost exactly in the midline, and you can see an enhancing soft tissue mass within the cyst, and this has been proved to be a papillary carcinoma of thyroid tissue arising within the thyroglossal duct cyst. This cyst is bigger than 2 centimeters, and I mentioned that the usual size is about 2 centimeters, but sometimes you can see that the cyst is bigger, like this one, and is exactly or slightly below the level of the hyoid bone. And these are the levels of the thyroglossal duct cyst. At the hyoid bone, 37%, infrahyoid 45%, and if you sum these two figures, and you see most of the lesions are located either at the level of the hyoid bone or slightly below. The cyst will be of fluid signal. On MRI, it will show a low signal in the T1 and a high signal in the T2. And sometimes the cyst may contain proteinaceous fluid, so it will show relatively high signal in the T1, and in the T2 weighted image you can see some debris like this, and this is not a mass inside the cyst. Then you see here a classic appearance of a thyroglossal duct cyst, a cystic lesion in the midline plane. And the lesion, if you inject contrast media, may show some peripheral enhancement, especially if it is infected. And here you see this is the appearance, the gross picture appearance of the cyst. And in this particular image, you see that the margin of the cyst is thick and is enhancing. The fat planes around the cyst are stranded. Then you think of infection. In order to treat these cysts, you need surgery, and the surgery should remove the cyst as well as the central part of the hyoid bone and the whole duct. Then if you resected only the cyst, there is an incidence of local recurrence. This is a sizable cyst which is partly located in the midline and partly to the slightly to the left of the midline plane. In the sagittal reformatted image, you can see that the cyst and its relation to the hyoid bone. Then you came to the branchial cleft lesions, and we have many branchial clefts. This is just an idea about the structures that can arise from each cleft. and this is the Eustachian tube, the tympanic cavity, and the mastoid from the first cleft, the tonsillar fossa and the palatine tonsils from the second cleft, the inferior parathyroid, the thymus, the piriform fossa from the third, the superior parathyroid glands, the piriform sinus apex from the fourth cleft. Okay, let's look at the branchial cleft cysts or the branchial cleft anomalies are usually in the form of three, either a sinus or a fistula or a cyst, which is the most common one. Bilateral anomalies are seen in about 3% of cases. In cases of branchial cleft sinus, you just see an opening on the neck discharging some of the discharge which may simulate pus, but whenever you inject contrast media, you cannot see any connection to the internal structures. The fistula, which is more common, you see an opening on the skin, and if you inject contrast media, you may got some connection to the pharynx, and this is what we call the branchial cleft fistula. And the cyst is just a cyst located in the lateral aspect of the neck at a very specific particular location. Then branchial cleft cysts are seen from the first cleft and the second cleft. First branchial cleft cyst is relatively uncommon, and it represents about 5 to 8% of the cleft cysts. And the best way for the diagnosis of this cyst is you can detect some relation between the cyst and the parotid gland. This is very important. If you see a laterally located cystic lesion in the neck, then you think of one of two. Either it is a branchial cleft cyst or it is a cystic hygroma. If the cyst is small, think of branchial cleft cyst. If the cyst is related to the superficial part of the parotid gland, then this is a first branchial cleft cyst. But the second, which is very common, representing about 95% of all branchial cleft cysts, and this is the age incidence, it has a very, very typical location. This location is related to the anterior aspect of the sternomastoid muscle, the posterior aspect of the submandibular salivary gland, and this appearance is almost pathognomonic, which is, and you see a tongue-like projection of the cyst between the branches of the common carotid artery, between the internal and the external carotid, and you see that the cyst is protruding or bulging between both the internal and the external carotid artery. This is typical location of a branchial cleft cyst. And the cyst is anterior to the sternomastoid muscle, posterior to the submandibular salivary gland. Sometimes you can see the extension between the two branches of the common carotid artery. And this is a big branchial cleft cyst in a typical location, anterior to the sternomastoid muscle, posterior to the submandibular salivary gland, and you may feel that this cyst is slightly protruding here. Then if the branchial cleft cyst is infected, it will be turned into an abscess, and the abscess will show marginal enhancement, and the fat planes around will be congested and showing some dirty appearance. Then by MRI, it is a simple cyst, and the cyst is of low signal in the T1, high signal in the T2, and if you inject a contrast, you may see some marginal enhancement. And the big sign, which I have mentioned, is the protrusion of the lesion between the internal and external carotid artery is almost diagnostic of this branchial cleft cyst. The third cyst in the neck is the cystic hygroma, which is usually located laterally between the neck and the thorax, and this hygroma is usually big. Then it is seen commonly in the childhood, and 90% of the cases are detected before the age of 2 years, which is the age of the greatest lymphatic growth. Then the cystic hygroma, as I have mentioned, is a laterally located cystic lesion in the neck and is sizable. A big cyst located in the lateral aspect of the neck, usually seen in a child, and this cyst is almost asymptomatic and painless. And this is a good example of cystic hygroma, and you see a huge fluid containing cyst and is protruding to the left side and extending deeply into the neck, and it may contain some internal septations. And this is also a good presentation of cystic hygroma, which is a fluid containing lesion in the lateral part of the neck and is usually sizable. This is also cystic hygroma in a male infant 3 months old. You see a big lesion which is cystic, fluid containing, may insinuate itself in the facial planes of the neck and may contain internal septations. Also, this is a good example of cystic hygroma. You remember that the cyst is big, but the branchial cleft cyst is small and it has a typical location. And this is cystic hygroma by MRI axial T2 weighted image. You can appreciate some internal septations within the cyst. Then we have finished with the 3 famous cysts in the neck, which are the thyroglossal duct cyst, usually located in the midline, the branchial cleft cyst, usually located on one side of the neck with a special or characteristic location, and cystic hygroma, which is a big lesion on the lateral aspect of the neck. Then we have some lesions in the neck with specific imaging criteria, and starting by the first one, which is very famous, and this is the paraganglioma. The paraganglioma or chemodictomas or glomus tumors are located at many sites in the head and neck, and these sites there are 4 common sites and many other less common sites. The 4 are located at the glomus jugular in the jugular fossa, the glomus tympanicum inside the middle ear, the glomus vagal along the course of the vagus, and the carotid body tumor, which is located between the bifurcation of the common carotid artery between the external and the internal carotid. These are the 4 common chemodictomas in the neck, but there are many sites but are uncommon, like the sella, the orbit, biennial body, the cavernous sinus, the larynx, the thyroid, the nasopharynx, the mandible, and also in the mediastinum. These sites are less common, and you remember that the chemodictoma or the glomus tumors can be unilateral and can be bilateral. The paragangliomas represent about 0.6% of head and neck neoplasms, and 80% of these lesions are located in the jugular fossa or at the site of the carotid body tumor between the bifurcation of the vessels. These lesions are hypervascular and they show intense contrast enhancement by CT and by MRI. These lesions are almost supplied by some of the branches of the external carotid artery, and these are the most common feeding vessels for any head and neck paraganglioma are the ascending pharyngeal branch, the ascending cervical arteries, and the posterior auricular artery. These are the common feeders, and when the tumor enlarges, other feeders will develop from the facial, from the lingual, from the posterior auricular, from the occipital, and so on. Then if you have an angiogram for a carotid body tumor, you see a hypervascular lesion with too many blood supply, and the tumor blush, as you can see here. Then the carotid body tumor is located between the bifurcation of the common carotid artery, between the external and the internal. This is the sagittal reconstructed image showing beautifully the site of the carotid body tumor, and this is the internal jugular vein. The age incidence is about 45 to 50 years of age, and it is considered a more or less benign lesion with a very slow rate of growth, and this lesion is usually not tender. It arises from the glomus bodies in this particular location, and the site is characteristic. Then you may have the reconstructed images for the carotid circulation, and you see the typical location of the lesion. And here you have bilateral carotid body tumor, the left side is bigger than the right one, and the multiple lesions can be seen in about 5% of cases. And there is a family history in about 20 to 30% of cases. The typical location of the lesion is at the carotid bifurcation. Then the presentation may be in the form of hoarseness, stridor, vertigo, and sometimes dysphagia, which all these symptoms are usually rare. And you remember, the lesion is almost asymptomatic. Malignant behavior is seen in about 2 to 13% of cases with metastasis, especially to the lung, to the bones, and to the lymph nodes. And this is a carotid body tumor between the bifurcation of the common carotid artery, and you see multiple nodular lesions in the lung representing lung metastasis. And you know that one of the famous appearances of the glomus tumors is what is known as the salt and pepper appearance. And this is a classic appearance on MR. Considering the size of the lesion, if it is more than 2 centimeters, then you can see the salt and pepper configuration, which is the appearance of the lesion in T2 weighted image. The lesion is bright, and there are too many dark foci representing the patent vessels within the matrix of the tumor, giving the appearance of the salt, which is the bright one, and the pepper, which is the black one. Then here is an appearance of a carotid body tumor between the internal and the external carotid arteries, the typical location of the lesion. But very importantly, here you see the MR angiogram did not show any vascularity within the tumor. And this is not the issue or the task for MRI, is to detect the vascularity within the tumor. But so we do not use MR angiogram for detection of the vascularity of any of the head and neck tumors, because it is unable to detect this. And here you see the tumor, and you see the bright signal in the T2 weighted image, and you see the splaying of the vessels at the characteristic location. And by CT, whenever you inject contrast media, you got significant enhancement and typical location, which is usually appreciated if you have the sagittal reformatted images. Then the glomus vagal is almost near to the site of the carotid body tumor, and the main difference between both is the carotid body tumor is located between the bifurcation of the internal carotid artery, while the glomus vagal is located posteriorly. It is displacing the internal and the external carotid artery anteriorly. Then whenever you see a lesion that is displacing both the internal and the external carotid artery anteriorly, and this lesion is conforming with the criteria of glomus tumor being a strongly enhancing hypervascular lesion, then you think of glomus vagal. And this lesion displaces the external and internal carotid artery anteriorly away from the jugular vein, while the carotid body tumor is located between the bifurcation, is playing both vessels away from each other. Then it's important in the axial images to appreciate the site of the internal and external carotid artery along the anterior aspect of the tumor. And if you cannot appreciate this, then you may have the reconstructed images, which are usually helpful in this particular domain. And this is an example of a lesion which is hypervascular. It may represent the carotid body tumor or glomus vagal, but the sagittal reconstructed image will show the tumor displacing the internal and the external carotid artery anteriorly, and this is the diagnostic criterion for the glomus vagal. And whenever you see that both arteries are displaced anteriorly and you think of a glomus vagal, sometimes it is difficult in the axial images to appreciate the difference between the glomus vagal and the carotid body tumor, but the reconstructed images are usually helpful. Then you remember the glomus tympanicum, which is a small hypervascular tumor within the middle ear cavity. And the main difference between this lesion and cholesteatoma lies in the enhancement pattern of the glomus tympanicum. If you inject the glomus tympanicum with contrast, it will enhance strongly. And I recommend, if you are evaluating a case of glomus tympanicum, you use or you select MR instead of CT, because by MRI you are able to appreciate enhancement more better than the CT. The diagnosis of glomus tympanicum is almost a clinical diagnosis. They look inside the ear, behind the drum, then you see a reddish hypervascular mass. But they usually send the patient for imaging in order to see the extent of the lesion and the adjacent middle and inner ear structures. And here you see a lesion in the on the left side, and by CT scan and by MRI T1 weighted image, and after contrast you got a strong enhancement of the lesion. Then you are dealing with the glomus tympanicum, not a cholesteatoma, because you remember that cholesteatoma do not enhance with contrast. Then glomus jugular is the tumor which is located within the jugular fossa. And if you look in the axial images, and you see an enhancing mass which is destroying the jugular fossa, and you know the intimate relation between the jugular fossa and the middle ear. So a glomus jugular may extend inside the middle ear, and then you got the glomus jugulotympanicum, as you can see many times in the literature. So if you look here and you see this is the site of the jugular fossa, and there is significant erosive changes, and the fossa is markedly enlarged. Sometimes other lesions can do this, like metastasis, for example, but you need the soft tissue window image, and you need the enhanced images to see the strong enhancement of the lesion. And this is an example by bone window to see the glomus jugular, which is destroying part of the skull base, and this is by angiogram. You see the tumor with tumor blush, and after embolization, and you got marked decrease in the blood supply of the lesion. This is also by MRI, and here you see in the T1 post-contrast axial and coronal a strong enhancement of the lesion, which is centered at the jugular fossa, and you can see some signal void vessels within the matrix of the tumor. And here is an example of glomus jugular, a strongly enhancing mass centered at the jugular fossa in the axial and coronal T1 weighted images MRI after contrast injection. And then the glomus tumor will appear of low signal in the T1, high signal in the T2, and in larger size tumor you can appreciate the salt and pepper appearance, and if you inject the contrast, then you got significant enhancement of the lesion. And this is a good example of a jugular foramen which is widened and eroded. So many lesions can do this, and the differential diagnosis include the jugular schwannoma. And schwannoma is a benign lesion. It does not cause too much erosion, but it may lead to widening of the jugular fossa, and there is no salt and pepper appearance, which is characteristic for the glomus tumor. And this lesion is not vascular or not hypervascular on angiogram, but the glomus tumor is hypervascular. And this is an image showing the normal appearance and the regular outline of the jugular foramen. Then if you got hypervascular deposits from renal cell carcinoma or thyroid cancer, in the positive clinical history of primary malignancy will support the diagnosis of metastasis. Meningioma can also occur in the jugular foramen. It will widen the foramen, but the wall may be sclerotic and is not destroyed or eroded. Normal anatomic variation, sometimes you got a sizable jugular bulb on the right side and a smaller one on the left side. It may be dehiscent or non-dehiscent, as I explained in the lecture of the petrous bone. Then jugular bulb thrombosis, the jugular foramen will be intact, and you got high signal in the T1 due to the clotted blood. Then the second issue in the neck, after we have finished the glomus tumors, is the nerve sheath tumors, the neurofibroma and the schwannoma. And the schwannoma may be related to the vagus, like the vagal schwannoma, or elsewhere in, as I have explained, in the parapharyngeal space lesions, and I said that the posterior compartment near the carotid space may contain these neurofibroma or schwannoma, and is considered one of the three main differential diagnoses in this place, which are the glomus tumor, the schwannoma, and the enlarged lymph nodes. Then schwannomas, you know the criteria of having a cystic component, and they usually have central areas of breakdown. They do not have a strong enhancement similar to the vascular tumors. They have a variable degree of contrast enhancement, and the lesion sometimes have a characteristic location, and this is one of the characteristic locations in the posterior triangle of the neck, and this is a neurofibroma showing heterogeneous enhancement, and this is MRI, and T2 weighted images indicate the brightness of the tumor. Then lipomas can occur anywhere in the head and the neck, including the parotid, as I have mentioned, including the larynx, as I have mentioned also, and also anywhere in the neck, like this fat containing lesion seen posterior to the submandibular salivary gland. Of course, you know that this is the density of the fat and not of fluid, because the density of fluid is a little bit higher. Then this is also a bigger lipoma in the neck, extending deep in the prevertebral space, and the same density of the subcutaneous fat is appreciated within the lipoma. You remember also, if the lipoma contains other soft tissues, then you may think of liposarcoma, which is rare in the head and neck. Coronal reconstructed images will show the craniocaudal extension of the tumor, and if there is an extension across the midline. Then hemangioma of the neck is also one of the known lesions. It can also occur in the orbit, it can occur in the parotid gland, it can occur in the neck. And hemangioma is a strongly enhancing vascular lesion. It is usually not seen at birth, but it's seen shortly after birth, and it may regress, show some spontaneous regression by age. Then on the T2 weighted image, hemangiomas will appear very bright, while in the T1 they have variable appearances, and you may got philippuli inside the lesion. And this is an appearance of a classic hemangioma in the neck, showing a strong contrast uptake. And this is hemangioma by MRI T1 weighted image. You see vascularity inside the tumor, and T2 weighted image, and it is the strong enhancement in the T1 post-contrast fat suppressed image. Then in the course of cirrhoid aneurysms of the face or of the head and neck, you may got an extensive vascular abnormality or an arteriovenous malformation extending into different facial planes and also affecting many parts of the neck. Then lymphoma is also one of the lesions that may show characteristic appearances on imaging. And you remember that I always mention that lymph nodes of lymphoma are bulky and they are homogeneous and do not contain calcium. Then here you see bulky lymph nodes in the submental area and bulky lymph nodes in deep to the sternomastoid muscle. They are homogeneously enhanced and they do not contain calcium and do not show areas of breakdown. Then whenever you see appearances like this, then you think of lymphoma. And this is a pathologically proved lymphoma. There is a big mass formed of lymphadenopathy extending in the retrotracheal area, and this is gallium-67 citrate scintigraphy, which is one of the specific isotopes taken by lymphomatous tissue, and it was at a time a helpful examination to differentiate lymphoma from other pathologies. And this is also non-Hodgkin Burkitt-like lymphoma, proved by histopathology. You see a big mass on the right side of the neck. It displaced the thyroid gland anteriorly and is extending into the right side of the neck. You remember, or you should remember, that the best way to characterize neck masses that do not show typical imaging criteria is to go by fine needle aspiration guided by ultrasound. And this is one of the basic techniques now routinely performed for sampling lymph nodes to assess the possibility of metastatic disease and to sample any lesion which is not showing classic criteria as those I have mentioned. And I thank you very much. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala ashraf al-mursaleen. Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in.